Um, 1 in 5 adult women.
Yeah, it's a staggering number when you really think about it.
It is. I mean, that is the statistic from our stack of medical journals today that absolutely stopped me in my tracks.
Mm-mm.
1 in 5 adult women experience stress urinary incontinence.
And because it's still, so heavily stigmatized, people just suffer in silence for years.
Right, which is heartbreaking. And that silence ultimately leads to over 120,000 surgeries annually in the U.S. alone.
Hundreds of thousands of women.
Exactly. Hundreds of thousands undergoing invasive procedures, largely because they feel like they have no other options.
Hmm.
But what if major surgery isn't the only answer?
That is the big question.
It is, and that is the mission for our deep dive today. We are taking you through a really fascinating stack of clinical studies, medical journals, and device patents to understand how a completely non-surgical approach is, like, changing the entire landscape.
It's a total shift in how we approach the anatomy.
Yeah, we're looking at how temperature-controlled radiofrequency devices are being used to target specific pelvic structures, stop stress leaking, and literally remodel tissue from the inside out.
Okay.
Let's unpack this. Because to understand the technology, we have to completely rethink the underlying anatomy of the problem,
We
right?
really do. I mean, historically, when people heard the phrase urinary incontinence, the medical community and the general public just assumed there was a fundamental failure of the bladder itself.
Like it's just a faulty reservoir or something.
Right, exactly. But to actually fix stress urinary incontinence, or SUI, you have to look entirely outside of the bladder. The modern understanding is rooted in something called the integral theory.
And the integral theory was a massive aha moment for me in these sources.
It completely shifts the focus away from the bladder, right?
Right.
And it moves it on to the surrounding pelvic architecture.
Uh-huh.
So the integral theory basically posits that the core defect in female stress urinary incontinence is actually a structural failure in something called the pubourethral ligament, or the PUL.
So for everyone listening, try to picture a hammock. If you can visualize the female pelvic floor as this, like woven hammock, resting right in the middle of that hammock is a water balloon.
Which is the bladder.
Right, that's the bladder.
Yeah.
The pubourethral ligaments, the PUL, are the ropes tying that hammock to the trees. They specifically anchor the anterior wall of the bladder and the proximal urethra securely to the pubic bone.
Yeah, and those ligaments consist of vaginal and urethral parts joined together by these really thin, fibrous threads. They are the primary structural support system keeping everything suspended and aligned.
Wow. Okay.
But the critical vulnerability here is that the main structural component of those ropes is collagen. And collagen, unfortunately, is highly susceptible to deterioration.
Yeah, the sources outline a pretty unrelenting list of things that cause that deterioration. It's essentially just life.
Right. Very much, yeah.
It's the physical trauma of labor and vaginal delivery. It's the hormonal shifts during menopause. And it's simply the natural aging process.
The collagen just degrades over time.
Right, causing those ropes to stretch, thin out, and fray. So the hammock sags.
And when that hammock sags, it creates a condition the medical literature calls urethral hypermobility.
Hypermobility, yeah.
Or some researchers use the term funneling, which I think is a highly descriptive way to look at it. Because the structural support is compromised, the pelvic floor can no longer withstand sudden increases in intra-abdominal pressure.
And we're talking about everyday actions here.
Right.
A cough, a sneeze, laughing at a joke, going for a run.
Literally anything that forces downward pressure. Normally, that pressure would compress a well-supported urethra closed against the pubic bone.
Like pinching a straw shed.
Exactly. But because the ligaments are loose, that pressure transmission is just lost. The bladder neck drops, it opens up like a funnel, and involuntary leakage occurs. The mechanical seal is essentially broken.
Which brings us to the traditional medical response. Historically, surgeons looked at that sagging hammock and decided they needed to go in and add artificial ropes.
Right, the synthetic slings.
Yeah, they perform mid-urethral sling procedures like tension-free vaginal tape to physically reinforce that structural support. The data shows that since 1995, over 1.2 million of those synthetic sling procedures have been done worldwide.
It's been the gold standard for a long time.
But looking at the root cause, I just found myself questioning this default approach. I mean, if the fundamental issue is just degraded collagen in those specific ligaments, why are we surgically inserting artificial mesh? The body built that collagen once.
Right.
Isn't there a way to trick the body's own biological machinery to build new collagen naturally?
That underlying biological question is what birthed the entire field of non-invasive energy-based urogenic collagen.
Oh, wow.
It really
Yeah.
brings us to the core of our patents and clinical data today. The focus of the recent breakthroughs lies in harnessing radiofrequency, or RF energy, to trigger that exact natural rebuilding process.
Now, the sources do mention a few different energy modalities, right? Including CO2 and erbium lasers, which use light energy, but they make a very clear distinction between lasers and radio frequency.
Yes, they are completely different animals.
So what is the fundamental difference when we are applying this to human tissue?
Well, what's fascinating here is that radiofrequency is not light energy. It is an alternating electric current.
Okay, an electric current.
Yeah. These medical devices emit a high-frequency current, typically ranging anywhere from 3 kilohertz all the way up to 24 gigahertz. When that electric field passes through the body, it induces this chaotic motion among the charged and polar atoms in the tissue.
Basically shaking everything up.
Exactly. The molecules are essentially trying to align themselves with an electric current that is flipping back and forth millions of times a second.
It's creating a microscopic traffic jam.
That's a great way to put it. And all of that rapid vibration, all of those colliding molecules, create severe resistance. In electrical engineering terms, we call it impedance.
Impedance, right.
The tissue's natural resistance transforms the electrical energy into thermal energy. It creates heat. And RF is uniquely suited for this specific anatomical problem because, unlike light-based lasers, which can be absorbed differently depending on skin pigmentation or surface moisture, RF actually thrives in tissue that is naturally moist and well-hydrated.
Which perfectly describes vaginal and labial tissue.
Exactly.
They are highly hydrated environments, making them ideal conductors.
Ah.
So we are using electrical impedance to generate deep thermal energy. But how does simply heating up the pelvic cavity fix the frayed ropes of our hammock?
Because the heat triggers a brilliant, highly documented dual action mechanism.
Okay, dual action, so 2 steps.
Right. The first action happens immediately on the table. When the thermal energy hits the existing frayed collagen fibers in the pubourethral ligament and the endopelvic fascia, which is the massive 3D web of connective tissue wrapping the pelvic organs, it causes an instant denaturation.
Denaturation, meaning it breaks down.
It shrinks. The triple helix structure of the collagen fibers literally unravels and shrinks. This instantly reduces the compliance or the looseness of the surrounding tissue.
Okay, I get it. It's like throwing a stretched out wool sweater into a hot dryer. You get an immediate physical tightening effect.
That is exactly what happens.
But that is still just shrinking the old, damaged collagen. Where does the new structural support come from?
That is the second long-term action. The heat acts as a biological alarm bell. It initiates a natural, localized inflammatory cascade by triggering the release of heat shock proteins.
Heat shock protein.
Yes. These proteins rush to the site and stimulate the fibroblasts. Fibroblasts are essentially the biological manufacturing plants in your body responsible for synthesizing structural connective tissues.
Okay, so we're waking up the factories.
Exactly. By subjecting them to this specific thermal stress, you force them into overdrive. It's a process called neocollagenesis and neoelastogenesis.
The creation of brand new collagen and elastin fibers.
Right.
But the literature makes it pretty clear this isn't a quick fix, right? You don't walk out of the clinic with brand new ligaments that same day.
Oh, no. No, it takes time for the body's manufacturing plants to build new structural matrices. The clinical observation shows this remodeling process happens gradually over roughly 90 days.
90 days, so about 3 months.
Over those 3 months, the body replaces the weak, disorganized fibers with dense, neatly aligned new collagen, fundamentally restoring elasticity and tensile strength to the weakened pubourethral ligament.
We are quite literally rebuilding the ropes of the hammock from the inside out.
We really are.
But I have to pause here because there is a glaring, massive elephant in the room that I guarantee you, the listener, are wondering about.
Oh, I know exactly what you're going to ask.
We are talking about applying rapid, alternating electrical currents to generate intense heat inside highly sensitive internal female anatomy.
Right.
How in the world does a doctor do this without causing catastrophic burns to the patient?
It is the ultimate engineering hurdle, and overcoming it all comes down to the precise science of temperature control. There is an incredibly narrow, therapeutically ideal temperature range for this biostimulation to work. We refer to it as the Goldilocks zone.
The Goldilocks zone. So the tissue has to get hot enough to wake up the cellular factories, but not so hot that it causes permanent damage.
Precisely. For neocollagenesis to occur, meaning those new cells generate cleanly without forming rigid scar tissue, the target tissue must reach between 40 degrees and 45 degrees Celsius.
Okay, 40 to 45.
If you fall short of 40 degrees, the heat shock proteins basically ignore you, and the fibroblasts stay dormant. But if the dermal tissues exceed 50 degrees Celsius, you cross a dangerous threshold into thermal injury, irreversible tissue damage, and cell necrosis.
Wow, so the margin for error is tiny.
Very tiny.
Well, here's where it gets really interesting, because the patents in our stack detail the engineering solutions used to thread this needle. Devices like Thermiva, which is featured prominently in the clinical studies, rely on a brilliant feedback mechanism. The tiny treatment tips on these probes contain integrated thermistors and thermocouples.
And those built-in sensors completely revolutionize the procedure. They monitor the local tissue temperature in real time, pulling data every few milliseconds.
They establish an automatic, closed feedback loop directly to the RF generator on the cart, right?
Yes.
So if the probe detects that the vaginal tissue is creeping up to, say, 45.1 degrees, the generator instantly throttles back the power. It completely removes human error.
Exactly. The doctor isn't guessing how hot the tissue is based on how red it looks. The machine is actively preventing overtreatment or thermal burns.
That is so smart.
And this raises an important secondary challenge about the depth of the treatment.
Right, because the ligaments aren't on the surface.
Exactly. The ligaments we need to target are buried deep beneath the mucosal lining. The patents outline an even more advanced thermodynamic technique utilized by some of the transurethral devices, like the Renessa system. It relies on a concept called the reverse thermal gradient.
Yes. I was staring at the diagrams for the reverse thermal gradient in the patent filings, and the physics seemed totally counterintuitive.
It's wild, isn't it?
You were trying to heat the deep structural tissue, basically the basement, without burning down the first floor.
It's an incredibly elegant solution to a complex biological problem. Look, if you apply the necessary heat directly to the surface epithelium, which is the very delicate lining of the urethra, you would completely destroy it.
Oh, wow. Right, okay.
So what they do is the treatment probe actively flushes the surface epithelium with continuous sterile water irrigation. This cools that top layer down to a chilly 0 to 10 degrees Celsius.
Wait, so they are practically freezing the surface while simultaneously blasting the layers beneath it with heat.
Exactly. Concurrently, the RF energy bypasses that cooled surface layer entirely. It targets the submucosa, which is the deep layer of connective tissue and blood vessels beneath the lining and the ligaments, heating them to a subnecrotic 65 degrees Celsius.
65 degrees Celsius. But wait, that is way above the 50-degree danger zone you just mentioned earlier.
It is an extreme temperature, but because the energy is localized purely in the deep submucosal tissue and the fragile surface is heavily protected by that near-freezing irrigation, the system safely triggers massive localized collagen denaturation without damaging the mucosal lining at all.
That is wild.
You have a highly controlled gradient going from near freezing on the surface to 65 degrees deep inside the tissue structure.
It really is a thermodynamic masterpiece.
Right.
But let's step out of the physics lab for a second and bring this back to the person actually experiencing this,
Sure.
What does this highly regulated thermodynamic engineering look like for a patient walking into a clinic? How do you actually reach these buried ligaments?
The clinical reality is surprisingly straightforward, which really explains the rapid adoption rate. Unlike a synthetic sling surgery, these procedures are performed in a standard clinical office setting.
So no hospital stay.
Right. There is absolutely no general anesthesia required, which removes a significant layer of risk. Depending on the specific device being used, the doctor might use a local anesthetic injection or even just a topical numbing agent like EMLA cream. And the entire treatment protocol is typically completed in under 30 minutes.
That's incredible. Less than 30 minutes. Let's look closely at the two main approaches detailed in the clinical trials, because they target the anatomy from two entirely different access points.
Okay, let's do it.
The first is the transurethral approach, which utilizes devices like the Renessa system we just mentioned.
Right, and in this approach, the physician is actually navigating through the urethra itself to reach the target zones.
The physical profile of this device is just fascinating. The doctor uses a 21 French transurethral probe.
Just for clarity, for anyone listening, French is a standard medical gauge used to measure the diameter of catheters. A 21 French probe is roughly 7 millimeters in diameter, so it's quite small.
Okay, so very small. The doctor inserts this probe through the urethra and into the bladder. Then, a tiny balloon inflates at the tip, anchoring the probe perfectly stationary against the bladder neck.
So it can't move around.
Right. Once it's locked in place, 4 microscopic nickel-titanium needle electrodes deploy outward from the shaft of the probe, piercing directly into the submucosa of the bladder neck.
This is exactly where the reverse thermal gradient we discussed is utilized.
Ah, okay.
The sterile water flows through the probe to cool the urethra, while those deployed electrodes deliver the high-frequency RF energy into the deep tissue.
The clinical protocol is incredibly precise, too. The system delivers energy to 12 discrete, microscopic sites of the bladder neck. Then the doctor partially deflates the balloon, pulls the probe back slightly, and delivers energy to 24 additional sites in the proximal urethra.
And that creates 36 precise circumferential sites of thermal collagen denaturation, which structurally tightens the entire upper urethral passage.
Wow. And then the second method, detailed in the sources, is the transvaginal approach, which utilizes bipolar RF devices like the Thermiva.
Yes, a completely different entry point.
Instead of going inside the urethra to target the tissue, this approach treats the interior vaginal walls to remodel the support structures sitting directly underneath the bladder.
And the physical probe used here is totally different. It is a slim, gently S-shaped wand with a small postage stamp-sized RF emitter located on the ventral tip. The doctor basically just glides this over the tissue.
The patents for these transvaginal probes are incredibly explicit about the anatomical precision required to do this safely. Like, when a doctor is treating the anterior wall of the vagina to support the bladder, they are instructed to strictly target the tissue in an arc ranging from the 1 o'clock to the 11 o'clock position.
Right. So if you visualize a standard clock face transposed directly onto the vaginal wall, the doctor sweeps the probe back and forth across that wide upper curve. However, they meticulously avoid the direct 12 o'clock position.
Because the urethra is sitting directly behind that 12 o'clock spot.
Exactly. The objective of transvaginal RF isn't to blast the urethra directly with thermal energy. The goal is to safely heat, remodel, and tighten the surrounding endopelvic fascia and the pubourethral ligaments, the structural hammock itself, without transferring excessive heat to the perivaginal tissues or directly impacting the organs.
It's all about stabilizing the surrounding architecture.
Precisely.
So, here's the ultimate question for you, the listener. Does this actually work? We understand the integral theory, we understand the cellular mechanics of fibroblasts, and we understand the thermodynamics, but what actually happens to the women suffering from SUI?
Well, the clinical outcomes across the multiple independent studies in our stack paint a highly compelling picture. The data really bridges the gap between theoretical physics and tangible patient relief.
In the transurethral studies, researchers tracked patients using something called the 1-hour pad weight test. And for anyone unfamiliar, this isn't a subjective questionnaire.
No, it is highly objective.
The patient wears a pre-weighed absorbent pad, drinks 500 milliliters of water, and then spends an hour doing physical activities, walking upstairs, coughing, doing jumping jacks, picking objects off the floor.
All the things that trigger leakage.
Right. Then, the pad is weighed again to measure the exact volume of leaked urine in grams. The RF treatment groups showed drastic, quantifiable reductions in pad weight.
Yes. Specifically, a comprehensive study by Chintakanan and colleagues demonstrated a 69.6% success rate at the 1-year mark using objective metrics.
That is huge.
It is. Furthermore, in the transvaginal RF clinical trials, investigators reported a 72.2% positive response rate at 6 months and an enduring 68.5% response rate at 12 months.
But beyond just the physical pad tests, the studies heavily feature the ICIQ-SF, the International Consultation on Incontinence Questionnaire short form.
The quality of life metrics.
Exactly. This is a validated survey that measures how much this condition is destroying a patient's daily life. Are they avoiding social events? Are they terrified to exercise? The scores on these quality of life surveys plummeted after treatment.
Which means their overall quality of life skyrocketed. They regained their confidence and mobility. And crucially, the researchers didn't just take the patient's word for it either.
Right, they looked at the actual tissue.
Yeah, the histology reports where they take tiny punch biopsies of the treated tissue and examine it under an electron microscope, they mechanically proved the theory. They could visually confirm the dense, tightly packed neocollagenesis.
It's incredibly rare to see that perfect alignment of subjective symptom relief and objective microscopic tissue regeneration.
It really is.
So what does this all mean? Let's synthesize this deep dive. For the millions of women that 1 in 5 who have been quietly suffering from stress urinary incontinence, the medical field is experiencing a massive overdue shift. We are slowly moving away from purely treating the symptom with highly invasive surgical mesh and synthetic tapes. Instead, researchers are addressing the root cause, the age-related collagen degradation in the pubourethral ligaments. We are using pinpoint, temperature-controlled electrical currents to wake up the body's own regenerative cellular factories.
If we connect this to the bigger picture, this represents a fundamental paradigm shift in the field of urogynecology. The trajectory is pointing firmly toward non-surgical, energy-based biostimulation as a primary intervention.
Definitely.
But it is important to look at this data objectively. I mean, these devices are not magic wands.
Right, they aren't a guaranteed fix for everyone.
No, they don't guarantee a 100% cure rate, and highly severe cases of anatomical prolapse or SUI will likely always require a surgical approach. But the clinical evidence clearly demonstrates that for mild to moderate SUI, harnessing impedance and the natural inflammatory cascade is a viable, highly effective frontier.
It truly is a frontier, and understanding the mechanics of how this works leaves me with one final provocative thought for you to consider.
Oh, I like where this is going.
If the medical community can use precise, temperature-controlled radiofrequency to trigger fibroblasts and successfully regenerate the frayed collagen in the pelvic floor, I mean, could this exact same non-invasive technology eventually be deployed to regenerate other failing ligaments throughout the human body?
That is a fascinating question.
Could a specialized RF probe one day be used to rebuild a frayed ACL in the knee or a torn rotator cuff in the shoulder, completely preventing the need for major orthopedic surgery? If the body's manufacturing plants are just sitting there waiting for a localized heat shock signal to start building fresh collagen again, where else can we turn them on?
It really makes you wonder what's next.
It really does. Something to mull over. Thank you for joining us on this deep dive. So curious.